Okay, I think we're just about at the 6:30 mark. Let me see. Okay, I'm hoping everyone was able to get on easily for the link once they registered. Good evening, everybody. My name is Gail Nixick with ElderWorks Educational Services. If you've possibly attended some of our webinars, both consumer and professional, we're always delighted to bring presenters on that could give you some great information. And tonight is certainly one of those evenings where you will be getting a lot of wonderful information. I am just to also know that this webinar is being recorded. For those people who do have any questions throughout the presentation, please use the chat box. We will get through your questions throughout the evening. So I would like to introduce Robin Dawson tonight. Robin is passionate about helping clients navigate Medicare to find coverage to meet their needs within healthcare needs and budget. With 25 years of experience managing client relationships, Robin will simplify the process of evaluating insurance options so you can make an informed and cost-effective decision. And Robin has also authored articles and quoted in publications such as Chicago Health, Caregiving, and Seniors Blue Book. So I would like to introduce Robin Dawson. Thank you so much for joining us, Robin.
Thanks for having me, Gail. I really appreciate the opportunity. I want to thank everyone for coming tonight. I know you probably had a myriad of other things you could have enjoyed on this evening, and I'm glad you chose to contribute to your knowledge in Medicare for this short evening. As Gail mentioned, we're independent health insurance brokers. We represent virtually all of the insurance companies in this state. Not every single one, but the majority of the big ones. And we just help people navigate this process, because what we've found over the years is that people come to this journey initially, and then throughout the aging process, they feel a lot like this guy. And that is not uncommon. You're not alone. Every person that kind of comes to this juncture and throughout their lifetime in Medicare, there's a lot of moving parts, especially initially, to navigate. And if you were lucky enough to have employer-sponsored insurance through your spouse's work or your work, you never really had to think about all the moving parts that go into choosing plans and evaluating deductibles and coinsurance amounts and out-of-pocket expenses. And now you do. And layer on to that the piece that you have to do with the federal government, and things can get really complicated really quickly. But one of the things Gail knows about me, and she's known me for a little bit now, is that I'm really passionate about this subject. And I don't think that a complicated topic needs to be confusing. And so the objective tonight is really to break down the parts of Medicare. Yes, I am a health insurance agent, but tonight is purely educational. I think there's power in having knowledge, and I want you all to be able to make fully informed decisions, not only when you come to Medicare, but throughout the aging process. So a couple of things that I like to do is share with people the government resources that are out there for you. I can appreciate the fact that somebody might not want to, begin this process sitting down with a health insurance agent like me, right? People are worried they're going to be sold, but there's a lot of preliminary research you can do in advance. Coming to tonight's webinar is one of them. Utilizing the resources that the ElderWorks team has at their disposal can also help you. But the government does have a few things that I think are really good. One is this Medicare and You publication. The unfortunate part about it is you don't get it until you're signed up for Medicare. So the place that you can get it is my second favorite resource, which is Medicare.gov. So back to the book for a second. What this publication does is it will answer a lot of very basic questions that you have initially in Medicare and then throughout the aging process. It'll talk about enrollment periods and penalty periods, and what if I sign up for Medicare and I have other group coverage, and it'll talk about timing and like I said, the penalties, and then things like supplement plans and advantage plans and drug plans and how they work. Your basic coverage in Medicare is covered here. But the one thing I want to caution everybody about is that the Medicare resources specifically put out by the government, you have to understand that they're written for the masses. And so there's a lot of partial sentences, half-truths, floating asterisks, and I'm going to try to point out some of them tonight. But one of the things that I want you to realize is that they have to address a broad population of people. So your specific situation might necessitate one answer to a the exact same question that another person asks. So just realize that is what's going on with some of these things. But this is the Bible of my industry, Medicare and You. You can download a copy of it actually on the Medicare.gov website. Now, the one thing I want you to be aware of is that URL exchange. It's Medicare.gov, not Medicare.com. Medicare.com is a sales site. If you go to that site and you type in your name and information for a free quote, guess what? The minute you hit send, your name is going to get sold and your phone's going to start ringing off the hook. So please stick within the .gov URLs. Social Security is SSA.gov, Medicare is Medicare.gov, the Centers for Medicare and Medicaid are CMS.gov. So this is the official website. I like to use this little suitcase tab down here, this Find Health and Resources tab. We use this as a lot to help our clients evaluate plans initially and make their plan selections. You can also create an account, log in all your medications to evaluate your Part D drug coverage. And then there are just everything on this website is a clickable link. So good news, bad news. If it's on here, you'll find it. It might take you a few clicks to get through, and it's a bit of a rabbit hole. Once you start clicking around, you might get lost, but there's always a good search box that can kind of bring you back to where you need to be. But Medicare.gov is where you start. If you hit this Get Started tab to learn about how to sign up for Medicare, it will ultimately push you to the Social Security website, because at SSA.gov is where you actually sign up for your original Medicare benefits, Part A and B. Okay, so the Medicare and You book, Medicare.gov, and then my third favorite government resource is 1-800-Medicare. Those folks have staffed that phone bank with agents that can answer just about any question you might have in Medicare. It's different than calling the Social Security office, okay? You really do get a live person. They're open 24/7. Almost 365 days a year. I think they're closed for something like 6 national holidays. But if you're lying awake in bed at night at 2 a.m. and you want to figure out what to do about your Part D prescription drug coverage this fall during the annual enrollment, you can call those folks and they'll answer the phone. Now, one tip I will give you, this is my PSA announcement, so your information doesn't get stolen. Medicare, Social Security, the Centers for Medicare and Medicaid, nobody will ever phone call you. Okay, the government likes to communicate with us via mail. So the only time you'll ever get a call back from somebody at 1-800-Medicare is if you have called them. And if you have given them a task or project or question that they can't necessarily answer for you, you can get their name and their badge number. And if they tell you that they're going to call you back, when they call you back, you can ask them for that name and badge number to identify themselves, okay? And then you can pick up where you left off with the same agent. So just know that Medicare won't ever call you. And there's a lot of telemarketers out there and call centers out there that will have enough information about you, and they'll make statements like, we've been assigned to your case, and we can see you're about to turn 65, and can we help you navigate here, here, and here? And the reality of it is that's a sales agent trying to win your business. So please try to stay within the government websites and know that they will correspond with you via snail mail. So a couple of things before we move on. I'd like to level set, because I'm not always sure when people come into this virtual forum, who's in Medicare, who's about to come to Medicare. But I want to appreciate the fact that everybody on this call might have a different understanding of what Medicare is. So to level the playing field, Medicare is our health insurance for persons 65 and up. That's what's considered the Medicare eligible population. Now, from time to time, there are individuals based on certain disabilities like end-stage renal disease, Lou Gehrig's disease, that may qualify for Medicare under age 65. You may know someone that went on disability when they were 30. And after being on disability for 24 months, on the 25th month, they actually qualify to get their Medicare Part A and B benefits. Now, they don't have to take them, but they qualify to get them. But for the majority of the population, you have to be 65 years old before you age in to your Medicare benefits. The one thing that I want to explain, though, is that Medicare, and I hope you feel tonight by the end of our meeting, that Medicare is a really good, it's really good coverage for what we pay for it, but it was never designed to be complete. So this last sentence here is what I really want y'all to kind of focus in on. There are a lot of gaps in Medicare's coverage. Places where Medicare has us, the insured, responsible for financial out-of-pocket expenses, deductibles, co-payments, co-insurance amounts. Okay, Medicare was never designed to cover everything, and it was always designed for us to have some skin in the game. Okay, some contribution financially that we need to make. So we're going to break down tonight what the moving parts of Medicare are, what they cover, what they don't cover, and more importantly, what are your options to kind of bridge that gap and fill those gaps with insurance products that can help keep you financially secure and sound. So this is where your journey begins. When you decide to come off of your Affordable Care Act policy, or maybe a retiree plan, or maybe your group insurance policy, you decide you want to come to Medicare and have Medicare be your primary insurance, you're going to turn on both Part A and B. And everybody has the ability to make that choice when they turn 65. They actually have a full 7 months around their 65th birthday in which they can make their enrollment in Medicare through the Social Security office. Now, again, partial sentences. If you've surveyed some friends and family who have embarked upon this journey before you, they may mean you well, but they may also throw you into a panic and tell you, you have to sign up for Medicare right away when you turn 65. Well, that's a partial sentence. People who have to sign up for Medicare when they turn 65, at least Part A, are individuals that perhaps don't have enough tax contribution into the Social Security system. Medicare says if you've worked or your spouse has worked at least 10 years or 40 working quarters, and you've contributed into the Social Security system through tax contribution out of your paycheck, your Medicare Part A benefit is already paid for. Okay. Some agents will tell you it's free. It ain't free. You paid a boatload in taxes for it, but you've already paid for it. So Part A, if you're one of those individuals that has a zero premium Part A, you don't necessarily need to turn it on when you're first eligible. However, that might not be everyone in the population. So if you don't have those enough credits in tax contribution, or if maybe you've been paying into a pension your entire life and not the Social Security system, you may have a premium to pay for Part A. And in that case, you do have to turn it on when you are first eligible at age 65, or you will face a penalty. Now, Part B, this is the piece that sometimes people will defer on. In my parents' generation, most people's Medicare cards had the same month and year in which they turned 65, they retired, they turned on Medicare, and everything, kind of happened at the same time. But the baby boomers are really changing this dynamic. They're working longer, they're deferring on their Medicare benefits past age 65 because they have group insurance that they're utilizing based on, actively working past age 65. So they might wait to turn on their Part B. They could just turn on their Part A, but it would sit in the secondary position behind their group insurance benefits if they're continuing to actively work. The kind of insurance that you can't hold on to and defer on turning on Medicare Part B is things like Obamacare. So if you're individually insured and have an Affordable Care Act policy, they want you off that and in Medicare by age 65. Maybe you retired at age 55 and your company loved you so much that they gave you a retiree benefit that carried you on the group health plan until age 65. But because that is a retiree product, it's not based on your active work status. You also have to get off of that when you're Medicare eligible. COBRA is another benefit that you have to terminate once you're Medicare eligible. Again, it has to be group coverage that's based on your or a spouse's active work status. And that employer also needs to have at least 20 or more people. If it's a really small company, you have to turn on Part A and B and make Medicare primary. Your group insurance can be secondary, but you might want to also evaluate that option compared to some of the other Medicare options out there. So general rule of thumb is you have 7 months around your birthday. You can enroll in that window or not. You can turn on just Part A or Part A and Part B, or you can defer on both. It really depends on your particular situation. One thing I will tell you about this enrollment window around your birthday is it's important from a timing perspective if you're coming off of group coverage, because you cannot choose when your Medicare benefits start in this window. It is chosen for you based on the month you apply. So here's the rule of thumb. If you want your benefits to start on the first of the month in which you apply, or I'm sorry, in which you're eligible, which for everybody is the first of the month in which they turn 65. Doesn't matter if your birthday is the 15th, the 25th, the 3rd, you're eligible on the first of that month. The only people who are eligible a month ahead of time are people whose birthdays fall on the first of the month. Okay, otherwise, everybody else, you can enroll in the 3 months leading up to your birthday. You can go into the Social Security website or go into the office or schedule a phone enrollment. They'll take your application and your benefits will start on the first of the month of your birthday. If you wait until the month of your birthday to apply, that's fine. Your Part A benefit will start the first of that month, but your Part B benefit will be delayed by 1 month. And then if you enroll in months 5, 6, or 7, the 3 months after your birthday, your benefits will be delayed according to this chart. So the important thing to know is that your Medicare Part B benefits are always forward on the enrollment, and they could be delayed by 2 or 3 months if you're in that 7-month window. And that's important if people are trying to time, coming off of group coverage and starting in Medicare. Once you're past that 7-month window around your birthday, this chart no longer applies. Then you can put in your application for Medicare. Your Part A will always start retroactive 6 months from the date you applied, but it will go back no further than the first of the month in which you turned 65. But your Part B will be processed to start the first of the month after you apply. Okay. And that will happen under a special enrollment for loss of coverage. And you will have a separate form that you'll need to submit with your application that shows, yep, I've had employer group insurance or some other creditable coverage since I turned 65. And that'll tell the Social Security office 2 things. Number one, not to calculate a late enrollment penalty for you for Part B. And number 2, that you can sign up when you're trying to sign up. Okay. Now, if you miss those enrollment windows, your initial enrollment window at age 65, your special enrollment when you later came off of group coverage due to retirement, you always have the first quarter of any calendar year to sign up for Medicare A and B. The problem with signing up in the first quarter is that everybody, no matter if you signed up on January 2nd or March 15th, everybody's benefits get delayed to July 1st. So you're looking at a delayed start, and you're likely going to have some penalty that accrues for the period of time where you didn't have coverage. Okay. Now, why do people delay in particular? They sign up for A because it has no premium, but why do they delay on B? Well, because B does have a premium, and it also might potentially be adjusted for your income. And that's what this chart looks like. So Medicare, just like our taxes, are means tested for income. The more you make, the more the government is going to take, the more Medicare is going to require you to pay. And what they'll do when you go to apply for Medicare is they will look at your most recent tax return. And if you are a joint filer with your spouse, or if you're an individual filer, you can look down these 2 columns, and you fall in one of these other brackets in terms of your modified adjusted gross income. That's the number they're going to look at. Your benefit could be increased. So you might have to pay more for your monthly premium for Medicare Part B. And unfortunately, for high income earners, that can get pretty spendy per month. If you are impacted by that income adjustment, and the acronym that Medicare uses is called IRMA, it stands for Income Related Monthly Adjustment Amount. But if you're impacted by it on Part B, they are also going to hit you with it on Part D, your prescription drug coverage. So when you enroll in a Part D drug plan, your plan might be $5 a month, your spouse's plan might be $25 a month. Whatever your price is for the insurance product, this IRMA adjustment is just going to be tacked on top of that monthly premium every month. Okay. Now, if you're not taking your Social Security benefits before age 65, if you wait and you do Medicare first, you're going to get billed for these premiums for Part B quarterly, and any income adjustment related to that. Once you start taking your Social Security retirement benefits, then the office just converts you to a monthly deduction. So this 170.10 will come right out of your Social Security benefit once you start taking it. If you're already taking your Social Security benefits, but you haven't yet turned 65 and enrolled in Medicare, you're going to be automatically enrolled by Social Security. because if they've got something to take that benefit from, they're going to take it the first of the month in which you're eligible. So if your card just shows up in the mail and you don't want your Medicare benefits turned on yet because you have other group coverage, and you just happen to be taking your Social Security benefits in addition, you're going to need to sign the back of that card and send it back in. Okay. So that's a lot of reasons why sometimes people delay on their Part A and B benefits. I think we have a couple of questions that might have come in really quick. This question was related to turning 65 and enrolling in Medicare, lost employer-sponsored health coverage the month before. Stayed in Medicare, how do I know if it's better to go with employer health plans? So you really have to do a cost analysis. I will tell you that when it comes to being Medicare eligible, having your Medicare benefits as an option, and also having a group insurance option, the power of Medicare really tends to kick in when you look at the deductibles and the coinsurance amounts, which we're going to do in a little bit here. You're doing yourself a disservice in evaluating your options if all you're looking at is the monthly cost for insurance. Okay, so I would definitely consider looking at both, and we're happy to help you do that as well. You can turn off your Medicare benefits though if you lost group benefits, jumped on Medicare, and then got a job where they gave you benefits again. But before you do that, before you kind of hop off Medicare, you're going to want to do that cost analysis, I think, to really see that that's the right decision. So there's 4 parts to Medicare. Part A and B form the foundation of your coverage. Okay, this is what's going to show up on your red, white, and blue card. Like I said, you can sign up for B's at the same time, or you can sign up for them at different points in time, but they are what we call original Medicare benefit. They just have 2 different pieces. Medicare Part C is a different idea. This is a private insurance product because, private insurance has now gotten into the Medicare space and has been for decades, to kind of help the Medicare system with the influx of insured members that are aging into their benefits. And so what happens with a Medicare Advantage plan is a private insurance company, they take over for Medicare in administering your benefits. So we're going to talk a little bit about Medicare Part C plans a little bit later this evening, but these plans are also an option that you can choose when you get to Medicare. Medicare Part D is something that you need to piece into your coverage when you sign up for A and B. Okay, if you're coming off of other creditable coverage that also had prescription drug coverage in it, and most employer plans do include their prescription drug coverage, you need to get Medicare Part D in place within 63 days of losing that coverage. Now, you can get a Part D benefit standalone, or if you choose one of these Medicare Advantage options, a lot of times it's built into those package options as well. Okay, so let's break down our foundational coverage, Part A and B. I put a handout in the chat at the top of the talk tonight. If you didn't grab it or you missed it, we can send it to you after the fact, but this is the first page of that handout. Like I said earlier, I like to make complicated topics a little more easy to understand, and I think visuals help. And so this is what I call the 10,000-foot view of Medicare. It's a diagram that really shows that when you start with Part A and B, and you come off of whatever other qualified coverage you previously had, there's 2 paths you can travel in Medicare. You can have your original Medicare benefits, and you certainly want to back those up with something like a Medigap plan, also called Medicare supplements, because they bridge the gaps or fill in, they supplement your Medicare benefits for your out-of-pocket expenses. And then you have to piece in your Part D drug coverage because A and B don't cover you for pharmacy dispensed pharmaceuticals. Your other option is you can choose a Medicare Advantage plan, also known as Part C, which is a managed care model. So we're going to break all these down and talk about the differences tonight. But before we do that, let's just talk about our foundational coverage. Medicare Part A, certainly a wonderful benefit. As I mentioned before, for most Americans, it doesn't have a premium when you turn it on because you've paid for it in tax contribution, not for everybody, but for most people. But it covers you for a few things, albeit very significant things. Your inpatient hospital care, that's an important distinction. It is inpatient hospital coverage. Your skilled nursing coverage. Now, this can be a post-acute care center, a rehab facility that you might have to go to, for a week or 10 days after a hospitalization, or it could be something that ultimately ends up to be your long-term care. But I do want to let you know that this is a limited benefit, and it is not long-term care insurance. Okay, and we'll see that in a minute here. Home health services, maybe you don't need to go onto a rehab center after that hospital stay. Maybe you can go home to finish your recovery, but you need a nurse practitioner or a physician's assistant to come to your home to do medically necessary things. Okay, this isn't grocery shopping and cleaning your house and helping you with your activities of daily living, but it could be someone changing wound dressings or administering medications, or doing physical therapy in the privacy of your own home before you can drive yourself to an external facility. So all of those types of home health services that are medically necessary, your doctor will write an order for it. It'll be short-term in duration, and it'll be a Medicare approved provider, covered 100% by Medicare. And then hospice is also a wonderful benefit, whether it's end-of-life hospice or hospice that leads you back to palliative care, whether it's in your home or in a facility, it is covered under Medicare Part A. So let's break down Medicare Part A from a financial perspective, because even though I said it doesn't have a monthly cost when you turn it on for most people, it definitely has financial exposure, and that looks like this. So the first night you're admitted into the hospital, Medicare's got your back. They're going to pay for everything that happens once you're admitted, but they're going to charge you $1,556 the first night you're there. Now that co-insurance amount or deductible, whatever you want to call it, it lasts for 60 days. So if you're in and out of the hospital, let's say you have an appendectomy and you're in and out within 3 days, and you go home, you're actually covered under that amount, that $1,556 payment, up and through day 60 after you're discharged. But on day 61, if you have a heart attack and you're back in the hospital, that benefit reset and you're going to get stuck with this a second time. If you happen to have a particularly unlucky or unhealthy year and you have 2 hospital admissions within a 60-day window, whether they're related to the same issue or not, you're not going to get tagged with that $1,556 a second time. Okay, but do know that the benefit does reset at day 60. Now, Medicare Part A certainly covers you beyond 60 days. The next 30 days, days 61 through 90, you flip to a per day copay, okay, of over $300 a day. And then we all have 60 more lifetime reserve days that take us from day 90 to day 150. And that's over $700 in a copay per day. Okay. And those amounts, they have no cap. Okay. Everything in Medicare is an unlimited benefit. Medicare is going to pay for everything you need it to pay as long as it's a Medicare approved charge. But your portion that you pay, it has no max out of pocket concept. Okay. If there's an unlimited benefit, it comes with unlimited exposure, and that makes people a little nervous. So just know that you're covered up and through day 150 with Medicare support, but you definitely are going to have some out of pocket expenses. Skilled nursing, like I mentioned before, it's a wonderful benefit, but I got to put an asterisk on this benefit, folks, because these first 20 days that Medicare says they will pay for, the benefit has a trigger. You have to have 3 nights admission, under admission in the hospital to trigger that benefit. Okay. If you're in the hospital 4 nights and 2 were under observation and they didn't admit you till the 3rd night, and then the last 2 nights were under admission, you will not have triggered this benefit. And if you go on to a rehab facility for a week, that entirety of that bill is going to be on you. Okay, so just know when you're in the hospital, you show that red, white, and blue card and you be your own best advocate. Ask people, what are we doing? Why are we doing it? Who's paying for it? And what's my status? And you want to know whether or not you're under observation or under admission. So let's say you had those 3 nights preceding. The first 20 days you're there, Medicare is going to pay for everything. But if you find yourself in a situation where you're there a little bit longer, okay, maybe you had a hip and a knee replacement and you've got stairs in your house and you need a couple of weeks there to get back on your feet, maybe a month. If you roll into the next 80 days, Medicare is going to charge you $194.50 per day. That'll be your copay per day during days 21 through 100. If you get to day 101, that's when Medicare says, okay, time out. We're glad we were able to support you for your first 100 days in this skilled nursing or rehab facility, But now you're in a bit of a long-term care situation because chances are you're not going home and we aren't long-term care insurance. Okay. So there's two options you have. You can either invoke a long-term care insurance policy that you might own to help pay for your days beyond 100, or you're going to need to pay out of your assets. Okay. So Medicare is not going to cover you for your residential care past 100 days. Home health services are covered at 100%. And then also hospice, a wonderful benefit that's generally covered at 100%. But to be fair, I put 5% copay because a lot of times we fill prescriptions to keep us comfortable at end of life. Okay, so that's Medicare Part A, no premium for most Americans, but definitely financial exposure. Medicare Part B. Now, Medicare Part B is what on our red, white, and blue card is called our medical coverage. Okay, but it's really I like to call it our services coverage, because any service provider that you come in contact with, if it's not a building like a hospital or a skilled nursing facility or a hospice center, it's going to bill to Medicare Part B. Okay. So this is all your doctors, whether you see them in their office or you see them in the hospital, whether it's a surgeon that operates on you, an anesthesiologist that knocks you out so the surgeon can perform the surgery. All those folks are going to bill to Medicare Part B. It'll be all your blood work and your biopsies, which would be things like lab services. It'll be any of the expensive diagnostic tests. This could be the EKGs, EEGs, MRIs, PET scans, CAT scans, what I like to call the expensive alphabet soup. It will be your durable medical equipment. Immediately, people will think about walkers and wheelchairs, and that is the case, but it could also be a COPD machine. It could be an insulin pump. It could be a pacemaker, lancets and test strips that you get through the pharmacy. They actually bill to your medical plan as durable medical equipment. So this could be a new shoulder, a new knee, a pacemaker, a variety of things. Physical therapy, occupational mental health therapy, those are all covered under Part B. Your ambulance services, so your ride to and from the hospital, anything that happens in the ER, okay? Any outpatient services. Now, this is a big and growing bucket of healthcare expenses. Why? Well, because there's a lot of medical miracles happening every day, and people are getting full knee and hip and shoulder surgeries done on an outpatient basis. So, a lot of times people go into these ambulatory surgery centers or they go into hospitals and they're in and out in the same day. They're never admitted. The entirety of that procedure might be outpatient. You might also go into the ER and the doctor doesn't want to send you home because they're not quite sure what's going on with you. They haven't made a diagnosis yet. So they keep you under observation. Okay. Maybe it's 24, 48 hours that you're still under observation. They haven't admitted you to the hospital until they make a diagnosis and have established a treatment plan. So during that window, all of the bills that you're incurring are going to bill to Medicare Part B as outpatient. Okay. And then the other bucket of pretty expensive charges could be clinical RX. Now, this isn't to be confused with what Medicare Part D as in drug covers, which are your pharmacy dispensed pharmaceuticals, whether it's retail or mail order. This is the stuff that is infused, injected, radiated. It's the rough stuff that you get in the doctor's office or in an infusion center. Chemotherapy, kidney dialysis, radiation therapy. Medicare is there and they've got your back to pick up those expenses. It could be joint injections for rheumatoid or osteoarthritis. It could be eye injections for some kind of ocular or macular issue related to your eyes. So those types of things bill to your medical plan. Okay. Now, Medicare Part B, as I mentioned before, it has a premium. That base premium for every American, unless you're getting state Medicaid assistance, is $170.10 per person per month. And we see that rise a couple of bucks every year. But in 2022, that's what the base number is. It's adjusted for income based on your tax return. And if that impacts you, you'll get a letter from Social Security about it. If you don't get the letter, don't worry about it. But it also has an annual deductible. Part B has a $233 annual deductible. Then Medicare takes their negotiated discount, which you're going to love. Okay. That is, call it that dash there. And then Medicare splits bills with you 80-20. They pay 80 cents on the dollar. You're responsible for 20 cents on the dollar. Now, as I mentioned before, if you have a group option, through your employer and you're continuing to work and you're not carrying a dependent or a spouse, it's just you and you become Medicare eligible. This is what I was talking about when I said, you got to look beyond the monthly cost for the insurance to what you're actually getting, because this deductible, folks, it's crazy low. I mean, if you talk to anybody who's on the Affordable Care Act right now, they're paying $1,000 just to go into an emergency room. And even very generous group insurance plans, I've seen, usually have about a $500 lowest deductible for their insured members. Usually it's a couple thousand. So this is a crazy low deductible. And then after Medicare takes their negotiated discount, which by the way would make a loan shark blush, you're going to get an 80-20 split on that. So your 20% coinsurance is on all these things after a nominal deductible, and Medicare pays their portion. That's the good news. The bad news is this 20% has no cap. So just like Part A, unlimited benefit, this is unlimited exposure for you as well. And most people aren't too concerned about 20% on an office visit or a blood panel or even a handful of physical therapy visits. But if you have an ER event, or if you have an outpatient procedure, or you're starting to get some diagnostic tests with regularity, MRIs or CAT scans or PET scans, that 20% can add up really quick, really fast, and you have no max out-of-pocket exposure on that, okay? So a lot of people, after they've got their A and B benefits ready to go, they look to add a Medigap plan to start at the same time, to bridge those gaps that they're financially exposed for. Now, the government has packaged together 10 plans that the population of Medicare beneficiaries can choose from. And that's the second page of the handout that's in the chatter that I'll email you after the fact. Maybe I'll pop it in toward the end, Gail, too, so people can grab it if they didn't catch it earlier. But these 10 plans are going to be on that chart in that handout. And all of these plans are available to anyone who reached age 65 or their Medicare eligibility prior to January 1st of 2020. If you're turning 65 after January 1st of 2020, there are 3 plans on this chart that you cannot choose from. One is Plan C as in Charlie, the other is Plan F as in Frank, and the third is the high deductible version of the F plan, okay? But all the other plans are available for you to choose from. Now, the important thing to know is Medicare defines what these plans cover. They just let private insurance companies bring them to the public. Okay, they let private insurance companies sell these plans, but Medicare says what they cover. So they're all the same, but there are different prices, obviously, by different insurance companies. Now, there are 3 plans that for a long, long time have really driven the market. I would say probably 90+% of all Medigap plans that people choose have fallen in the F, G, or N category. So I've highlighted those in red here. And the reason a lot of people choose them is because they're pretty easy to understand. I mean, if under this benefit column to the far left are all of those points of financial exposure that you're responsible for under Medicare Part A and B, when you go across the chart and you look in the F column, well, your supplement is going to pay 100% of your portion for everything, even the Part B deductible, that nominal $233. Okay. Now, if you don't qualify to buy the Plan F, Plan G is the next closest in coverage that you could choose from. It's the most extensive coverage for anybody who's reaching Medicare age now. The most extensive, though, rhymes with the most expensive. So expect that you're going to pay a higher monthly cost for a plan like this versus something like a Plan N, for example. Plan N and G are pretty similar. I want to point out a couple of nuanced differences for them. One is, in both cases, you have to pay that Part B deductible, but that's not a big deal. It's $233 a year. Okay. And then Part N, if you see these floating asterisks and you bring your eyes down to the bottom of the chart, Plan N will pay 100% of that 20% coinsurance that you're responsible for under Part B, but you might have a nominal copay for office visits of no more than $20, okay, and for ER visits of no more than $50. So if you're willing to take on the occasional copay for an office visit or an ER visit, Medicare caps those amounts, But if you take on that additional expense in addition to the deductible, they'll bring your premiums down even lower. Okay. Now, the high deductible version of this G plan and this F plan, those are kind of interesting because what those say is if you're willing to pay the 20% coinsurance and the deductibles and coinsurance amounts under Medicare Part A for hospital and skilled nursing, you actually, if you ever hit a max out of pocket on either of those plans in calendar year of $2,490, you're done paying. Okay. And then the plans would act like the standard version of themselves and cover everything after that. So you're minimizing the insurance company's risk because you're willing to take on the first, $2,490 worth of expenses. So you're essentially buying a firewall behind your Medicare benefits. But interestingly enough, for some people, remember Medicare Part B, after you pay that first $233, you're still only going to be on the hook for 20% coinsurance. Okay. So a high deductible plan isn't for everybody, but it doesn't mean that you have to pay $2,490 before the insurance kicks in and pays anything. You might pay your deductible, which would count toward that amount. You might pay 20% coinsurance on services, which might count toward that amount. And certainly if you were hospitalized, you'd have to come up with that $1,556 on the first night, but that would also count toward that high deductible number of $2,490. So it acts more like a max out of pocket. Okay. So how do we choose about these plans? Well, the first thing you need to understand is the Medicare rules that guide these plans forward. And the first rule is that the insurance companies have to take you when you first come. There are no pre-existing condition exclusions. Nobody can ask you anything about your health, and no insurance company can deny you coverage. But that window is finite, okay? And the clock starts ticking on that window when you activate Part B of Medicare and come off of other qualified coverage, okay? So that activation of Part B starts a time clock that runs for 6 months. And in that 6-month window, you can choose whatever product you want from whatever insurance company in Illinois that sells it, and you cannot be denied. But once that window closes, then you can still apply for a Medicare supplement plan any month out of the year because they're month-to-month policies. So you're not going to be locked into the annual enrollment to change your policy, but you will have to answer questions about your health and you will be medically underwritten. Answering questions in the application, maybe answering a phone call from an underwriter. And at that point, they might say, thanks, but no thanks. Either they'll deny you coverage, or if you've got some stuff going on and it's not, something that would disqualify you from coverage, but they deem you a higher risk, they might rate you up to a higher price point. Okay. So in the beginning, the only thing that really sets the price for you generally is your age, your zip code, male or female, smoker, non-smoker. Sometimes that doesn't even matter. It depends on the carrier, but really you want to pick the most coverage that meets your needs initially with a reputable company. Now, we tend to look at companies that are A-rated financially, the parent company, that have a good track record in the business. They know this space. They know how to operate a shared claims pool because the prices of these policies will go up as you age. And so we want modest rate increases year over year. And we can see that track record with companies that have a good reputation in the business and a large population of insured. And so that's really how you want to pick these. You also want to take a rational assessment of your needs. Okay. You may have been co-joined at the hip with a spouse or a significant other on group insurance up until this point in life, but now you can start to get really selfish and specific about how you use the healthcare system. How often do you see your doctors? How much backup coverage are you willing to take on and pay for? Okay. I have a tendency when I work with couples to see that there's, the women kind of want to move freely. They're more risk averse than the men who just kind of want to get in and out with the cheapest policy possible and don't want to have to think about it much. So, there's a lot of things to consider, but taking a rational assessment of your needs and choosing a plan that suits that would be my advice. You don't have to be same anymore. There certainly are discounts available if you and your spouse both get a supplement from the same company. You don't have to get the same level of coverage, but you might be able to avail yourself of those benefits if you kind of go with the same carrier. So one of the questions that came in was, what's the big difference between Plan F and Plan G? The $233 deductible. That's it. If you look at these two columns, everything else is covered at 100% except for that one empty box. And so what I will tell you folks is that even if you're eligible to buy Plan F, if you end up working with me or another independent broker, they might spend about 5 minutes to try to talk you out of it. Now, Plan F will really, you won't see a bill because it'll pay the deductible, it'll pay all your co-pays and co-insurance, but it's going to cost you a lot of money. And generally what I've seen over the last number of years since that legislation went into effect and F is no longer available for newly insured members is that they've kind of counterbalanced it from a rate perspective. So, you'll probably pay a lot more per year in insurance premium on a Plan F than you'll pay in a deductible right now at $233. Okay. So really, I try to help people find value on this chart. And when it comes to long-term value, I just think G is a better buy. The other thing you need to remember is when you buy one of these supplements, you're buying that letter plan from that insurance company. And the second rule that Medicare has, besides you got to take everybody when they first come, no questions asked, is you cannot single people out for a rate increase. And you can't drop them based on claims. The only time you can be dropped from one of these policies is if you fail to pay your monthly premium. So because of that, you're in a risk pool of people that's sharing claims as you age. That risk is being spread around. So for the older and the sicker, as we continue to age, law of nature is we're going to file more claims. We want backfill of young, healthy 65-year-olds into our plan every year. And if you buy a Plan F right now, you're not going to have that backfill of new, healthy, insured members because nobody can buy a Plan F except people whose 65th birthday were prior to January 1st of 2020. So that risk pool over time is going to shrink and claims are going to rise. And, you do the math. It's not going to be a far number of years out before we start to see the Plan F rates really start to escalate. So for those of you who might be on the call tonight and are already in Medicare, if you're a Plan F holder and you're generally healthy or could get through medical underwriting, you might want to consider shifting to a Plan G. You definitely will capitalize from bringing your rates down, but long-term you might also protect rate increases going forward. Okay, so taking a rational assessment of your needs here, choosing a good company, long-standing track record in the business, A-rated financially, good prices, taking advantage of discounts where you can. That's how we guide people through selecting this process. Okay, lots of companies to choose from in Illinois here, probably about 36 or 37 at the last count that I looked. Now, they all don't offer all of these plans, but most of them, the majority of them offer these popular ones. Okay. All right, so now we've got our backup coverage to our hospital and medical benefits from Medicare, but we still don't have prescription drug coverage. And that's the one piece. The government doesn't care if you get a Medigap plan. Okay, if you want to fly solo without it, that's your business. Now you know what you're going to be financially exposed to an unlimited amount, but they definitely want you to get drug coverage, even if you're not taking any prescription drugs. And they'll penalize you for it if you don't get it when you're first eligible. Okay. So the important thing to know about Medicare Part D is that late enrollment penalty. Now, folks, it's 1% of the average Part D premium in a calendar year on a drug plan. So I think last year it was about, or this year it was about 32, 35 cents a month, because the average plan was about $35, $36. So 1% of that is pennies, right? But what they do is they add up every month. They just cumulatively continue to add up the penalty for every month that you didn't have a plan that you could have had a plan. And then when you finally jump into a Medicare Part D plan, they add up all those 35, 36 cents and they tack them onto your Medicare Part D monthly premium in perpetuity for the rest of your life. So it's not a one-time hit. And the only people that can get that late enrollment penalty relieved are people that qualify for extra help or for state Medicaid assistance, which are generally people that are below a certain income threshold. Okay, so rule of thumb is don't avoid Medicare Part D. The good news is over the years, insurance companies have recognized that you all are coming to 65 healthier than your parents were at 55. Okay, you eat kale, you take walks after dinner, you drink fortified smoothies for breakfast, and you're not on prescription drugs at the level that maybe your parents were. And so there are a lot of people that are aging into Medicare and simply not taking anything. That's wonderful. But the insurance companies, their lowest cost plans years ago used to be average $35, $40 a month. This year we had a plan that was under $7 a month. Okay, so that's the plan we'll go to for somebody who's not taking any medications, just to get their foot in the door. Okay, so you have a lot of options. The more important thing though is if you kick the can down the road initially on Medicare Part D, you can only jump in during the annual election period. And that's right around the corner here. It's between October 15th and December 7th. You can pick up a drug plan and that plan will go into effect as of January 1st. Now, here's what tends to happen. I get calls, a handful every year. Somebody calls me, they went to go fill their medications or they went to the doctor and they got a new medication prescribed and they don't have a Part D drug plan. So their neighbor tells them, call Robin, she's the Medicare lady, she'll help you out. And the first question I ask them is, well, when are you coming off of your other coverage? Oh, I did that, 5 years ago. Oh, okay. Well, when are you coming to Medicare? Oh, that was 7 years ago. Okay. Well, guess what? I can't help you until October 15th. And then your benefits aren't going to start till December 7th. So while I can get them into a plan, it's going to have to be during the annual election period. And for the time in which they don't have that coverage until it goes into effect January 1st, they're going to have to pay full retail for that medication. Now, if it's a $20, $30 medication, they might be able to use a good RX coupon to get it cheaper. But if it's a $400, $500, $600 medication that doesn't have a generic equivalent, they're kind of stuck. And all I can do is, ask them to not, kill the messenger. I hate to be the bearer of bad news, but I see that happen to people quite often. So don't wait on your Medicare Part D. The other thing to be mindful of is a lot of times people will just go onto Medicare.gov, they'll look at the drug plans and they'll pick the cheapest plan. But one thing I want you to know is that these plans are not a one size fits all, okay? They are all covering a different set of drugs. Medicare sets a master formulary of all common prescription drugs taken in Medicare. And then off of that master formulary, each insurance company by plan decides what drugs they're going to cover and how they're going to tier them. Okay, so there are different formularies for every plan. What is common about these plans is that they all have 3 stages of coverage for sure. The initial stage of coverage, the coverage gap, which people refer to as the donut hole, and catastrophic coverage. Many of the plans, I would say most of the plans, also sometimes have a 4th stage, deductible stage. So let's talk about this tiering structure, because this is where things kind of go sideways for people a little bit. On that master formulary, drugs are tiered on a 5-tier scale. Your tier 1s and 2s are your preferred generics and generics. They have a low retail value. They're going to cost you maybe 0 copay at the pharmacy if you use a preferred retail partner, or maybe even mail order, but they're going to be low cost to you to fill. When you get to your tier 3s and 4s, these are your more expensive brand name drugs, your preferred brands and your non-preferred brands. They're the ones that are advertised on TV, maybe by famous spokespeople. Those are expensive, okay? They're going to cost you more at the pharmacy. They're typically going to trigger a deductible if your plan has one, and you're going to end up paying full price for them until you pay off your deductible. So just know that these plans these tiers will necessitate you paying more when you actually fill those drugs. And then tier 5 is specialty. So these are anti-rejection medication after transplant, maybe oral chemotherapy, maybe AIDS medication, things that sometimes you can get taken under clinical RX and billed to your Medicare Part B plan if you get them infused or injected. But if you get them dispensed in pill form, they could be very, very costly for you. Okay, so if you have an option, you might want to consider how you get that medication administered. Under the 5-tier system, as I mentioned, most plans have 4 stages of coverage. 3 for sure, sometimes 4. This is also in the 3-page handout. So you're going to have that overview chart, you're going to have the Medicare supplement grid, and then you're going to have this Part B stages of coverage. Now, here's the interesting thing. As I mentioned, some plans have an annual deductible, and this year Medicare set that deductible at a base amount of $480. Some plans have 0 deductible. Those generally are higher price plans because they're allowing people to get expensive brand name medications at a copay right out of the gate and not pay off the deductible. If your plan has a deductible, one of the things that you need to be conscious of is how that deductible applies on your plan, because on some plans it could apply on all the tiers. On other plans, it might only trigger on drugs that are in the higher tiers, tier 3, 4, and 5. So if you're taking all tier 1, tier 2 generics, not a big deal if you have a deductible on your plan, because if all of your drugs are deductible exempt, you're not going to have to worry about paying that off. Okay. So once you're past any deductible that applies to any of your medications, you're in what's called the initial stage of coverage. And this is allowing you to get some value of drugs. Let's say you have 10 medications you fill with regularity, and the retail value of all of those is $700, but your drug plan is letting you get them for a $70 copay at the pharmacy when you fill it. Here's the interesting thing. Medicare in the initial stage of coverage, they don't track the $70 you pay out of your pocket. They track the $700 your drugs are worth. And every month that you fill that list, they're adding up 700 plus 700 plus 700 plus 700. And when this year, in calendar year 2022, you reach $4,430 worth of drugs, then they say, okay, time out. We're glad we were able to support you in your prescription drug expense, but now we're going to move you into the coverage gap, also known as the donut hole. And I will tell you, it's not a sweet place to land, because in the coverage gap, you're going to pay 25% of the cost of all of your drugs. Okay, let me repeat that. 25% of the retail value of your brand name drugs, 25% of the retail value of your generic drugs. So the cost of your generics might go down, or they might stay the same. The cost of your brand name drugs, they're going to go up. Okay. And this is where people get stuck paying a higher amount for the exact same prescriptions that they were filling just 1 month prior. Okay. And they get stuck in this donut hole paying that 25% of retail, no matter what insurance plan that they're on, until their total drug costs have reached a $7,050 limit. Now, in the fall, Medicare might adjust these amounts. They might adjust the deductible for the coming calendar year. So we usually see these numbers rise a little bit every year. Okay, so the thresholds might rise, the deductibles might rise. So you need to pay attention to that. But one thing to be mindful of is that if you're filling drugs that have a high retail value, chances are you're going to fall into the coverage gap at some point in the calendar year. Now, that may happen early for you, and you may get to catastrophic coverage before the end of the year, or you may fall in the donut hole and never get to catastrophic coverage. But in Medicare, again, with prescription drug coverage, there's no max out-of-pocket concept. So the way Medicare manages your costs on Medicare Part D is they move you through these stages of coverage based on a combination of what you've paid and how the insurance has supported you. And then if you're on really expensive medications, they give you rate relief if you ever hit catastrophic coverage. The carrot and the stick here is they want you to start taking generic drugs if you can. Okay, this whole plan is designed around pushing people to take generic equivalents. The downside is we all know not every drug has a generic equivalent, or some people can't tolerate the generic equivalents. So it puts you in a little bit of a pickle. And then for the average person, you might have 1 or 2 expensive medications, but the rest of yours might be fairly inexpensive. So you might fall into the coverage gap around this time of year, late summer, early fall, but then you never reach catastrophic coverage and get that rate relief. If you do, however, reach that last stage of coverage, you'll pay no more than 5% of retail on your medications. There'll be a flat copay for brands and a flat copay for generics, but 5% of retail, whichever is the greater, is what you'll end up paying. The challenge here is that on December 31st, this all resets and everything goes back to 0 as of January 1st. So that's why, again, between October 15th and December 7th, you get a free do-over on your drug coverage, folks. Medicare realizes that this is a volatile part of people's healthcare, okay? People may go on and off medications, brands may go generic throughout the year, and they want to give people an opportunity to pivot, okay, without question. So you just have to be mindful of that timing. You got to do this between October 15th and December 7th, and then your new plan will go into effect as of January 1st. And certainly if you don't have coverage, you can also pick it up during that time. Now, you might say to me, Robin, this sounds pretty complicated. How do I figure this out? Well, that's where we go to my second favorite resource, right? Medicare.gov. We also have quoting software that pulls in Medicare.gov formularies and those from the carriers' websites, and we can kind of aggregate that information for our clients. But if you want to go it alone, Find Health and Drug Plans tab is where you want to go. You want to create your account. And by logging in and creating your account, what it'll do is it'll allow you to type in your medications, the name, the dose, how often you take it. It'll let you choose your pharmacies that you like to go to and fill those medications. And then it'll allow you to save that list. You can throw that list then against all the plans that are available this year and when the new ones are published in October next year, and make your plan choices accordingly, because your plan might not stay the same. It might not cover the same drugs. It might not cost the same. It might not tier your drugs next year the way it tiered them this year. Now, do you have to look at this every year? Not really. I mean, especially if you're on a handful of medications that are pretty benign, low cost, tier 1, tier 2 generics. Keep an eye out. I always tell people to keep an eye out for your annual notice of change. Your drug plan company will send that to you in the fall. Unfortunately, it comes at the same time that you also get a ton of insurance propaganda wanting you to switch your plans, okay? But pay attention to the collateral that comes from the insurance companies that you already have your products with, okay? Because those could be important. Those could be telling you something about how your plan is going to change for the coming calendar year. And then if you need assistance in navigating through this, give us a call, or you can utilize Medicare.gov as a resource. When you plug in all your drugs and you get a printout of all the drug plans that cover your specific list, you can click into each one and you can see how your drugs are treated, how they're tiered, what the retail cost is. When I get a printout like this person is paying about, $25 for this plan. CVS is a preferred and network pharmacy. That's an important distinction. There are preferred and standard, and preferred are always going to give you your lowest cost to fill. Okay. But then the other thing we're going to want to look at is this retail cost column right here, because if we can swap out some of these brand names like Eliquis or Ventolin for generic equivalents, we definitely want to do that. Now, I don't think there's a generic for Eliquis yet. It might be an FDA approval, but there is for Ventolin. It's called a Butyral inhaler. So we could save some money by swapping out the generics for that, and maybe not have to pay toward that deductible. But this plan, based on the $480 deductible and the way these drugs are tiered, the deductible will be met in January. The first time somebody fills that Eliquis, they're going to pay a lot for it. But then once they're past that deductible, they're going to get their Eliquis for $30, their Ventolin for $30, and their other 2 drugs for no cost, as long as they're using CVS or another preferred pharmacy on the plan. They're not going to hit the coverage gap until August. But that's based on the fact that every time they fill this full list, they're filling a retail value of $572. So that's going to cross them over that $4,000 threshold in about August. And then they're going to pay $143 instead of $60 for that same list. So when we look at an analysis like this, what we're really trying to do is maximize people's out-of-pocket expenses over the calendar year. But the way we can try to minimize cost for them really is between the deductible stage and the initial stage of coverage, because once they get to the gap, all the plans work the same. Okay, so that in combination with the cost for their insurance is how we try to look at this and help our clients make the best plan choices for them. Now, somebody put in the chat using GoodRx is something that they can do when they reach the donut hole. Yeah, I mean, you can use GoodRx for some of these other more expensive medications. Like if you know that you can get a Ventolin inhaler using a GoodRx coupon for cheaper than paying toward the deductible, or even cheaper than paying a $30 post-deductible copay, knock yourself out, do it. Medicare says you have to have Part D drug coverage. They don't say you have to fill all of your medications under your drug plan. So my advice to my clients is use whatever strategies and resources allow you to get the medications you need to stay well at the best price. But if you have to fill everything under your plan, we're going to help you do that in the most cost-effective way too. But a lot of people, if it makes no difference to them out of their pocket, if they use the insurance or use a GoodRx coupon, sometimes they'll fill a drug outside their plan using a discount coupon like GoodRx or CleverRx, simply just to avoid the retail value being calculated toward the coverage gap. So if you can use that strategy and delay your entrance into the donut hole by a month or two, you know, that could save you a lot of money as well. Okay. So all these are really good ideas in helping keep fixed costs for prescription drugs low. Now there is some pending legislation about caps on prescription drug expense, but frankly, we don't think that that's probably going to go into effect until 2025, even if it gets passed. So it's not going to be this next year thing. Okay. Now you've got original Medicare as one option. In terms of your coverage, you can see any doctor anywhere in the US that accepts Medicare. It does not matter who your supplement is with, okay, as it relates to your physicians. The only question you're going to ever need to ask somebody is, do you take Medicare? Because the government is your primary insurance, right? Your secondary supplement is just that. It's a secondary bill payer. So if Medicare pays, they have to pay. And then your Part D prescription drug coverage is going to be customized to you based on what you're filling. And the years might go by and you'll pay premiums and maybe you'll tweak this coverage every few years to bring your costs down or to reevaluate things. Or you might decide as the years go by that you're paying more in fixed costs for insurance with your drug plan and your supplement combined than maybe you might pay as a relatively low or medium healthcare consumer on a Medicare Advantage plan. Now, this is an either or choice, folks. You cannot have both, okay? But what you do have to have in place is Part A and B to travel either path. Nobody gets away from paying that Part B premium, okay? You have to have your Medicare benefits turned on and you have to be paying for those benefits. But if you choose a Medicare Advantage plan, what's happening here is the government has done a handshake agreement with some private insurance company, okay? And they're all the usual suspects that also play in the Part D space and the Medicare supplement space. So you'll recognize all the names, okay? But these insurance companies, they're providing managed care plans and they're running your benefits in Medicare. So they're taking over for the federal government. The government is saying, okay, you guys take care of Robin. We're going to give you her Part B premiums. We're going to collect them every month through her Social Security benefit, or we're going to bill her quarterly if she's not taken her benefit yet. But we're going to pass those premiums over to you, and you'll also get all the federal tax dollars that normally go to the Medicare system to make up the difference, okay? But you're going to be responsible for her, and you're going to give her all of her benefits that she's legally owed to get under Medicare Part A, Part B, and in most cases, there's also Part D prescription drug coverage. Not all, but in many, okay? And that package of benefits delivered by a private insurance company has a couple of nuanced differences than being over here in the original Medicare model, okay? The first nuanced difference is, number one, you can no longer see any doctor in the US that accepts Medicare because you are in a managed care plan. So by design, this plan might be an HMO, it might be a PPO, it might be a fee-for-service plan. Whatever the type of insurance it's going to be tied to a doctor network. So the first question that you have to ask if someone's assisting you like we do, or if you're doing it on your own is, are my doctors in network on this plan? Okay. The second thing you have to look at is the summary of benefits for the plan, because unlike a supplement that just pays your portion after Medicare pays, Medicare Advantage plans require you to pay a copay for everything beyond your preventive care. So all your preventive care, visits to your primary care doctor, those are going to be at no cost, okay? But what the Joe Namath advertising doesn't scream at you on TV is that Your specialist visits might cost between $35 and $40 a pop. Your PT visits might be $40 a visit. Your nights in the hospital might cost you $200-300 a night for the first 6 or 7 nights you're there. A pop into an ER is going to be $90. A pop into an urgent care is going to be $40 to $65. A lab test is going to be $10. An MRI is going to be $200, and so on and so on and so on. Now, all these co-payments for services that you pay in this pay-as-you-go model, they're going to count towards some max out-of-pocket. So that's the good news. You pay as you go, but you do have capped exposure on these plans. And as you would suspect, if you do everything in network, that number is going to be lower than if you're on a PPO, for example, and you utilize the in and out of network benefits. There's going to be a max out-of-pocket number that's much higher if you go in and out of network. Okay. If you're on an HMO version of one of these plans, you have to do everything in network. You pretty much have to be doing everything within one medical group because you're going to need a referral from your primary care doctor. So that max out-of-pocket number, while it might be low, a lot lower than on a PPO in network, it's going to require you to stay within a single medical group. Okay, your Part D most often is included. Okay, there are plans that don't have Part D drug coverage. Those are great for veterans or people who have other qualified Part D drug coverage in the eyes of the federal government. But for most people, when they come off the group plan, they also need the drug coverage piece. So they get one of these plans that includes the drug coverage. And the time that you can move in and out of these plans is during the annual election period. So just like drug plans that run on a calendar year, you can switch those up between October 15th and December 7th. You can change your Advantage plans, no questions asked, between October 15th and December 7th. Now, people often ask me, Robin, why isn't there medical underwriting to get a Medicare Advantage plan? Well, if you have co-payments for services and you're coming with a certain set of health challenges, the insurance company has figured out what they're going to charge you on a per service basis. So they don't lose money on you. Okay. But day one, dime one, you're contributing to the cost of your care. Okay. The insurance company's splitting bills with you. So in the Medicare supplement world, that insurance company is just paying your bills after Medicare pays to some varying degree, depending on the plan you chose. Okay. So that's the distinct difference between these plans. More restrictive networks, co-pay payments for services, capped exposure, but it's a package of benefits run by a private insurance company, not the federal government. Okay. A couple other things to keep in mind about Part C. You have to be enrolled in Original Medicare. All right. You have to be paying those Part B premiums. This is a private insurance product. So who you see and where you see them matters. Okay. Before, all you needed to ask your provider is, do you take Medicare? Now you have to ask your provider, do you take this Medicare Advantage, HMO, or PPO? Okay. And not every doctor is contracted with every plan. But these plans do replace Medicare in that they run all of your benefits. They're the administrator of your benefits. They're available and sold by county. So, a lot of people get well-meaning advice from friends and family when they start upon this journey. And you might have somebody that tells you, a relative, maybe they live in DuPage County and they love their Advantage plan from such and such an insurance company, but you live in McHenry County. That plan might not be available in McHenry County. Okay, so you have to look at the set of plans that are available in your county and choose from one of those. That's the first filter. The next filter is your doctors. The next filter is your medications. But you want to look at all of that when you're evaluating this model of insurance. The good news is that this package of benefits, these insurance companies aren't dumb. They understand that Medicare leaves you open to self-insure for some of your preventative care, like your dental and your vision and your hearing. You're covered for your eyes, ears, and teeth for illness and injury under Medicare, but they're not going to pay for 2 teeth cleanings a year. If you get a refraction exam for prescription eyeglasses or contacts, they're not going to pay for that. They're not going to fit you for hearing aids unless it's medically necessary or due to an illness or injury. So these types of insurance products you have to add if you're in the original Medicare model, but they might be baked right in at no cost in your Medicare Advantage plan. And that's really nice. Now, I wouldn't buy one of these plans for the extras, right? Because by Medicare law, These plans have to give you all your benefits under Medicare A and B. And if they have a prescription drug plan, it has to be a qualified plan, but they don't have to give you some of these bells and whistles. A lot of them do. It's the way they compete with each other and compete with Medicare. But, you know, as an agent, I've seen these benefits change a lot from year to year. So you really want to make sure if you're evaluating this model of insurance, and it could be a good choice for you, but you want to make sure that your doctors are in network, your drugs are covered, the cost structure within the plan on a per service basis is reasonable for you. And that max out of pocket number, it's something that you're comfortable with if you ever have a bad year health wise, because that's your worst case scenario. Okay. Now, what doesn't count toward that max out of pocket is your plan premium, if there is one, your deductibles. Okay. Actually, no, your deductibles would, but there generally aren't medical deductibles on these plans. But any copays or co-insurance for Medicare Part A and B services, medical services are covered. They count towards your max out of pocket. Your prescription drug fill does not. So if you are getting a fair amount of pharmacy dispensed pharmaceuticals, and that's a costly part of your healthcare, just know that what you're paying out of pocket for your prescriptions is not going to count towards your medical max out of pocket on these plans. All right. So that is your option when you fire up A and B and you come off of other under 65 or other qualified group coverage. You're going to want to definitely either look at a Medigap plan and a Part D drug plan, and you're going to get real specific about your needs, your budget, your lifestyle, your medications. Okay. Knowing that as long as your doctors take Medicare, they're going to be fine taking your supplement product in Medicare. Or you can look at a Medicare Advantage plan. Okay. Works a little different, is certainly a reasonable option for a lot of people. But you just need to know that it's more of a pay as you go model. Okay. I tend to favor the low cost, no cost plans on the Advantage chassis, especially if you're new coming to Medicare and you're 65, because the price of Medigap plans are relatively low, the younger that you are. So, you know, you don't want to have co-pays and co-insurance on top of a high premium plan. That just doesn't make a whole lot of sense to me. But it's certainly as the years go by and the price of some policies go up, you know, if you're, like I said, a relatively low healthcare consumer, you might flip over to a model like this thinking that it could save you money just based on your normal use of the healthcare system. But both options are open to you. When you first come throughout the aging process, you now know when you can change. But with that, I'm going to jump over to the chat and see if we have any other questions that came in. If you have something more specific to your situation that you'd like to ask me offline, feel free to email me or give me a call. One question I got was, if you're in original Medicare, how can somebody get dental coverage under another plan? We can help with that. There's about, 10 to 12 different insurance companies that we sell individual dental plans with. So you just add it. And you can do that with vision too. You can get like a VSP IMED type plan, something like that. Does Medicare cover any behavioral mental health services? It does. Yeah. Under Medicare Part B, therapy visits would bill. Okay. The important thing to know is that your mental health therapy visits or physical therapy visits, those are also covered under Advantage plans, but your therapist would have to participate in the plan or you'd pay out of pocket costs. And you typically have, there's a cost structure around individual versus group sessions, and then also around hospitalization related to mental health care. So, but yeah, it is a covered benefit.
Great. Thank you so much, Robin. There was so much information, and of course, someone gave you a nice compliment. You're a great educator. We greatly appreciate it.
Oh, thanks.
And then look at the website. There's also for some of the upcoming seminars, Robin will be very busy along with her colleagues presenting on Medicare. So can easily navigate this process because it can, as Robin mentioned, be a little, she'll try to make it softer for you to understand. It tends to be a little complicated, especially if people are just entering the space for the first time. Right. They hear all these things, then they don't know what to do. So you've made quite a bit of a great piece of information to help us along the journey. So thanks again for everybody for joining us. And then for those of you who had friends and family who weren't able to make it tonight, this particular presentation will be on the ElderWorks Facebook page tomorrow. We'll have the entire presentation. So please do share that with everyone. Well, thank you again, Robin. We greatly appreciate it.
You're welcome. I think we need to put the handouts in the chat once more, which I will be happy to do. I stopped sharing the screen, correct?
Correct.
Okay, so let me, okay, there are the handouts for anybody who needs them. And again, if you want to go to Medicare